It's nice to be here. It's about 3:30 in the morning for me because I got in yesterday. So if you find my seat dozing, you'll know why. Over my years with Vasyli, I really have enjoyed this association as much as any I've ever had. There's a real family orientation to them, and either it's with their family or with the broader Vasyli family. And it's really been a joy to work with a company that sees quality and value as the most important part of it. With, like Buckminster Fuller said, makes sense, you make money after that. So I think that's how we'll start. I'm going to be talking to you about management of chronic pain after ankle sprains. This is as much a talk about chronic pain as it is about pain and ankle sprains. And about what it is, how do we really feel pain? What is that about? Where does it come from? And what are the ramifications? How do you deal with it on a daily basis? How do you make these people better and let them go back to their lives in a normal fashion? Well, ankle sprain is a pretty common problem. I did a little looking into this and found out that there are 2,328, I don't know how they came up with that number, sprains in the US every day, not year. There are 850,000 ankle sprains a year. That's a huge number, and loading emergency rooms. It's limiting people's activities. You know the routine. The foot rolls over with damage done to the lateral structures of the ankle and the foot. It's not something unusual. Something we see regularly: pain, swelling of the outcome. There's often ligamentous injury. We know this. Nothing surprising here. You can treat these with immobilization. You can treat them with ice, compression, elevation, the standard Rice techniques. Here you could see the injuries could be to the anterior talofibular ligament, the inferior calcaneal fibular ligament, or even the posterior talofibular ligament. If they're ruptured and completely torn, that's one thing. However, you can also have high ankle sprain. Now, in a high ankle sprain, you've now injured the syndesmotic tissues which connect the fibula and the tibia. And these are a different set of injuries. They complicate it and make recovery even more difficult. These people hobble around. Professional athletes lose weeks, if not months, or even a season to this type of injury. The standard of care is immobilization. It's hold it in place. Keep it there. Don't let it move. Which at the time of the original injury is fine. There are many ways of doing it. The air cast, as you can see, that's a nice, neat ace wrap, but you know how they come in, they're sort of wrapped and curled and balled up, and how people treat themselves. There's ankle sleeves, and there are cam walkers. And these type of immobilization techniques are well known, they're well established around the world, people use them. It's fine, it's how you deal with it. But what is the pain generator? Why does it hurt when they come in 6 weeks later and they say to you, I can't walk on it. It doesn't move right. And the biggest common denominator amongst all these people is that sense of impending doom. Like, I'm going to roll this again. I feel like I'm going to go over on it again. Why do I feel that? What is happening? And the common answer was, well, you tore your lateral ligaments and you've lost the stability of the ankle, and that's what you're dealing with. Is that really the issue? Or are there secondary pain generators that are occurring because a chronic pain is not acute pain for a long time. It's a different mechanism. It's a change in how we sense pain versus the reasons for acute pain. So let's talk about joint motion and pain for a few minutes and see what that's about, and then we'll come back and talk about ankle sprain specifically and what you could do about that in a way to intervene. There is a relationship between motion and pain in the body that goes back as far as we've been bipedal. Motion and pain are inexorably linked. Think of hitting your thumb with a hammer, all right? What's the first thing you do? Do you swear? The second thing you do is you go like this, or you go like this, while you're still swearing. And you rub it, and you move it, and you do. But why? Why do you do that? because when you move it, you don't feel it, or not as bad, because you're stimulating the proprioceptors around the nociceptors, the pain sensors. And when you do that, you diminish the pain. And we know that, even though we might not know that that's why we're doing it, we know as humans that you shake it or you rub it or something like that in order to relieve some of those symptoms. And this sort of dates back to when we were not only predators, but we were prey. And if you fell and turned your ankle or hurt yourself somewhere in the tundra while you were running around and some animal was coming and you looked like lunch, if you couldn't get out of the way, you were lunch. But you could start to run and get out of the way and have your pain-sensing system be overrode so that you would have a few minutes to get out and into protection, into safety. Well, that mechanism now, I mean, now we hunt and shop and save, or whatever the local supermarkets might be. So now those problems, you don't get eaten, you just have chronic pain, and you limp, and you walk around in a distressed way. Pain is perceived in the body by the primary afferent nociceptor. It is the thin C fiber that's non-myelinated. It's the red one on the far end. And it is the slower conducting of the nerves, slowest conducting of all the nerves because it's non-myelinated. It has no insulation cover to it. It's designed to create a physiologic warning when you've reached the limits of joint motion, tissue compression, or application of heat. And it's a warning signal. But as you know, if you've ever hit your thumb with a hammer or done anything that you sprain your ankle or you fall, you know you've done it. And there's a slight delay. And when the delay happens, then you get that throbbing pain. This year in the NBA, in the National Basketball Association, Shaquille O'Neal, who was this gigantic man, he was trying to recover from some injury, and he finally came back and was running up the court. And you could see it on TV. He's running up the court, and as he's running, all of a sudden he turns around, and he looks, doesn't see anything, takes one step, and starts to limp. Looked to me like he tore his plantaris tendon in the back of his leg. But you could see the time delay. He heard it, and he turned to look at it. Didn't see anything, started to run, took 2 steps, and the pain began, and he literally crawled off the court. But that 2-step delay is part of this delay process. And how these pain processes develop. The nociceptors are the free nerve endings, and they're grouped with the faster conducting proprioceptive nerves. And they are heavily myelinated, and they conduct very rapid signaling. And they're grouped together, so you have the free nerve endings, which is marked there, or you can have the grape-like structures, which are the proprioceptors, which are here. And they're all grouped together, as you can see. They surround the joints. They surround the tissue, anywhere where you can feel pain. However, in the cartilage surface, there are no pain sensors. There's no nociception within the hyaline cartilage. So it sort of makes you wonder whether arthritis is really joint pain, or is it periarticular joint pain? That it's around the joint, not in it, because there's no sensation of pain there. Now, if you erode the cartilage to subchondral bone, that's different. Now there are nociceptors there. So you have to start to think, what is joint pain? What is that really about if there's no sensor within the cartilage itself? So that would be the subchondral sensor, but in the cartilage, there's none. Well, pain is variable. It's modulatable. You don't have a pain threshold. I mean, some people have different sets than others, but it's not fixed. Think about the last time you had the flu. You know, when you start to get sick, everything that ever hurt you begins to hurt you because the infection somehow is dropping your threshold. And now the things that used to bother you, whoa, I forgot. I thought that was better, and it starts to ache, and then you realize, oh man, I'm just sick. But it starts to trigger that. And so those sensations change within the body. Nociception and proprioceptive nerves synapse together at the wide dynamic range cells in the dorsal horn of the spinal column. In fact, 85% of the nociceptors connect there and mix with proprioceptive nerves. When there is abnormal proprioceptive input, you can create a sensitization to nociception. And now, all of a sudden, less and less movement begins to be perceived as more and more pain. And literally, there's a neurologic confusion between what's moving and what's hurting. So movement and pain now are confused. What's fascinating about this is depending on where the input into the cord is and then where the output is, and it could be 3 spinal levels away, the sites that are affected may not be the site that was actually injured. And so now you have to sort of search your way around and see what happens and find out where this is, which makes this so complicated at times. But that's what referred pain phenomenon is all about, that the source may not be the location of where you feel pain. So you have these nerves that link in, and then loop back out again. And now that sets up an issue where all of a sudden you may have a situation where pain results, and it can be dramatic. Because pain sensation is not just, I hurt my toe, it goes into not even up as high as your brain, it goes into your spinal cord and then loops back around again, and you feel pain. It works 2 ways, just like everything in the body. It's way more complex than it looks. So you feel pain, signals the central nervous system. That's the classic way. However, the CNS is capable of reversing that dynamic. And that's called antidromic function. That all of a sudden, nociceptors are just signaling this way, but the central nervous system can now send signaling the other way. And now these nerve endings secrete chemicals. And those chemicals are known as neuropeptides. So nociceptive hypersensitivity can result in a variety of issues. Number 1 is the secretion of these neuropeptides. Substance P, that's what's depleted when you use products like capsaicin, where they burn the skin almost, and they cause that substance P to be secreted to the point where it stops. Calcitonin gene-related peptide is another one. This has been heavily implicated in migraine headache. And so these chemicals are secreted. That's why in migraine headaches you get first either an aura or the pounding, then the constriction, then the opening again, because these chemicals can promote vasoactivity. Think of Raynaud's phenomena. That's very much associated with these kind of secretions. That happens, and you get a constriction and then a dilatation, and it opens up. Sometimes they're associated with pain, other times not. These chemicals, though, are very, very sensitizing to the distal ends of the nerves, and so they can create a hypersensitivity just from their own secretion. So now you're not only confusing motion and pain, the pain sensors are so sensitive that just looking at them creates an issue that's off the top, and that can lead to reflex sympathetic dystrophy type symptoms. Complex regional pain is a newer way to describe it. But if you think about, the young girl who comes in, she's 12 years old and sprains her ankle, she's immobilized, it's 8 weeks later, she can't bear weight. MRI, X-ray, all these things are done. It's normal. There's nothing there. There's no damage. Well, is she faking at 12? Highly unlikely. What's wrong? Her nervous system is confusing what's moving to what's hurting. Think of that. That when you try to move them or you try to stroke it even, they just, don't touch it, don't touch me, don't touch me. Because it's their system that's broken, not the part. So now you have to say, okay, how do I now work my way into this and figure out what is it that's wrong? Is it a motion-related issue? And if I constantly immobilize them, joints are made to signal when they move. It's when they're fixed and don't move that they send this abnormal proprioceptive signaling that then reflexes back and creates this phenomenon. It's a lot of ligaments. They're all over. Ligaments are very heavily proprioceptively innervated. And so ligaments become extremely important in understanding what this process is about. But when you start to look at the mechanism of the injury, you start to realize where some of these restrictions are coming from and how to best manage them. If you're playing basketball and you come straight down on a jump and land on somebody's foot, it's easy to see an inversion sprain. But that's not the only part of the mechanism. Most of these things are happening when you're running forward. So if you look at our footballer on the right, on my right, and realize how far his center of gravity is ahead of his foot that's planted on the ground, if he's going to go over on that, not only is he going to go this way, but he's going to fall forward at the same time. And so now what happens is that you not only have an inversion injury, you have a rapid adduction injury too, where the leg is rotated, it inverts, and then rotates internally, right at the same mechanism of action. And so what happens is the forefoot works as a lever against the rear part of the foot, rotating internally and adducting it rapidly. And so the tibia, which is pretty firmly anchored to the foot, is going to rotate internally, and the fibula, which you could think of as almost like a floating bone, because it certainly needs to move, and we'll talk about that in a minute, during normal ambulation, the fibula ends up being stuck posterior to the tibia. The fibula really stays there. It's the tibia that rotates internally, leaving the fibula relatively posterior to it. Once the foot and ankle invert, it's that forward motion now forcibly adducts the forefoot on the rear foot. The tibia will rotate, and the fibula is left posterior. Why is that a problem? Because in order for the ankle to dorsiflex, the wider part of the talus has to slide into the ankle mortise. It's shaped like a truncated pyramid where the narrow end is heelward and the wider end is toeward. So that as the ankle dorsiflexes, and we tend to think of these motions as, we sit and we hold feet and we move them back and forth. That's great. My friend Joe Wernick in New York says, but the really way you should examine somebody is grab them by the feet and hold them by the neck and pull them over the top, because that's how they're moving. Your foot's on the ground, it's pretty planted, and everything is moving around it. Usually forward, but that's essentially what's happening. And so in order to progress over your foot, your ankle needs to dorsiflex, and it dorsiflexes about 10 degrees past 90 when the knee is fully extended. For that to happen and for the wider part to fit in, you need the ankle to open, and that's the role of the fibula. It translates, it undergoes a motion that's cranial and lateral. So it moves up and slightly out, opening the mortise, allowing the ankle to be able to dorsiflex so the wider part can fit in. And it's that translation that allows for this full-range dorsiflexion with the knee extended. When the fibula is restricted, it blocks this ankle joint dorsiflexion, but it also creates what's known as an arthrogenic inhibition. It inhibits the perineal muscles on the lateral side of the leg. Now, all of a sudden, you have an inhibitory weakness that develops. It's not like if I lifted enough weights, it would get stronger. Muscles receive signals from the central nervous system that either turn them on or facilitate them, or inhibit them or weaken them. And that's normal. So if you're sitting at your computer keyboard, if you're sitting and typing at your keyboard, when your finger comes down, your flexor tendon is excited, your extensor is inhibited, and vice versa. I mean, imagine that I were lifting a barbell, and I was working it like this. If I fire my bicep, that's going to lift the weight. But why don't I smash myself in the face with the weight? A, I hope I'm smart enough not to, and B, because I have a tricep. But if the tricep were on while I fired my bicep, what's going to happen? I can't move the weight. So the body, in its ingenious design, facilitates this, inhibits this, just enough so I'm lifting it, but I have enough control so I don't go smash. But I need the power here. But if I reverse that and did a reverse curl, I'd inhibit my bicep and my tricep would work. Well, that inhibition excitation is about stance phase muscle activity and swing phase muscle activity, and the body does this normally. It always does it. It inhibits muscles that it wants to be toned down and excites muscles that it wants to be toned up. But when you restrict the fibula and you inhibit the perineals, they become chronically inhibited. And now this weakness develops, and that becomes a different set of circumstances. And in addition to that, because of its lack of motion, you can have associated nociceptive hypersensitivity. Well, this is a complicated problem all of a sudden. You have all this stuff going on, You have weakened muscles, you have nociceptors that are hypersensitized, and you have joints that don't move. Now, the picture of why people are chronic in ankle sprain should start to crystallize a bit. The peroneals, longus and the brevis, can be recruited to resist rapid inversion as you're rotating your ankle. Peroneus longus crosses directly beneath the cuboid and courses from the lateral side of the foot to the medial side of the foot and inserts under the base of the metcuneiform joint. It's right there. And when we look at the bottom through the peroneal sulcus in the cuboid, you can really see how it passes directly inferior to it and on that same line right to the base of the first ray, which would be right here. This is just exactly where it's going to insert. It's going to be right there. Hold the first ray against the ground, stabilize it to prevent its dorsiflexion. And so as the forefoot is rapidly inverting and adducting, the peroneals are going to be recruited to try to resist that so you don't go over so much. But what's happening is, where are they located? They're underneath the foot, and as it's rotating inward and they're resisting, what's going to happen? Well, what's going to happen is that now the peroneals are going to evert the cuboid, because there's so much force inverting the foot that now the cuboid is going to rotate. And when the cuboid rotates into almost a pronated position, it now causes the entire lateral column to lose its range of motion. There's no more lateral column dorsiflexion that exists. Nociceptive hypersensitivity now exacerbates pain. So this rotation of the cuboid that's happening as you sprain your ankle is not involving the ligaments of the lateral ankle. It's a whole other problem. And the muscular inhibition creates the following scenario. That would be an inhibited peroneal muscle. So now it fires normally when you sprain your ankle, but then after the injury, now it's inhibited, so now it can't really repronate you. So now we have a scenario like this, where you have a tiny amount of force coming from the peroneals, but the posterior tibial is not affected by that process. So now the posterior tibial works normally, but there's no counterbalance. So what happens to the weight? It's going to shift laterally, because now you have the peroneal, the posterior tibs, moving the weight. Who gets blown up? Me. The lateral side of the ankle now is where the weight goes. But that's where the injury was. So now it's like, having a headache and hitting yourself in the head with a hammer and wondering why aspirin isn't taking the headache away. It's no secret. Lose the hammer, you're going to feel better. But here, the hammer is a very subtle problem. What it is a gait issue that's happening thousands and thousands of cycles a day over and over and over again. And so you could look at this with immobilization as the answer to the problem, but now as I'm talking about it, should be, wait a minute. If everything's already immobile, why do I continue to keep it immobilized? And that's because the problem is not that obvious. And so you keep keeping people in casts and keeping people in casts and keeping people immobilized. And what happens eventually is that now you almost create the RSDS state. So manipulation becomes a treatment of choice here. That what you want to do is mobilize these structures that are stuck, get them moving, and what happens is the pain will very often and dramatically resolve. And so there are three major issues associated with chronic pain: lack of motion, nociceptive hypersensitivity, and chronic inhibition of the peroneals. Those are the three things that add up that really create prolonged pain and severity. And if you look carefully at the origins and insertions on the fibula head, you realize that the peroneus longus and soleus originate from it, and the biceps femoris connects directly into it. I'll talk a little bit more about biceps femoris in my second talk about back pain. But this fixation of the fibula is very related. I mean, people with back pain always talk about tight hamstrings, but the hamstrings have to connect to the fibula. The fibula's got to move. The fibula doesn't move. The hamstrings are always tight. So there's a very cause and effect relationship there as well. Okay. So what you want to do is you want to see, are the peroneals inhibited? So examine for that. If these people, look, if they've just sprained their ankle and they come to you with a fresh injury, it's not, you don't want to show them how strong you are and how weak they are. That's just stupid. I mean, because they're hurting. But what you want to do is you want to gently see if they could resist an eversion motion. And so you stabilize with one hand, and what you're going to do is you're going to ask them to hold their foot. You're going to try to invert it while they hold their foot everted, and you watch that they don't dorsiflex their ankle instead. Because one of the most common substitutions for peroneal inhibition is anterior tibial firing. Is that 2 minutes? Whoa. I don't want to go too fast. I'm going to take 5 more. So what happens is that that's been the founder of the think tank. This helps. Because the anterior tibial muscle goes to the same location underneath the foot and the insertion of the medial basic cuneiform as the peroneals. And so all of a sudden, you can now use anterior tibial to substitute. Problem is, anterior tibial is a swing phase muscle, not a stance phase muscle. You use muscles out of phase, you get pain. So there's people who sprain their ankles or who have anterior leg pain following. This is why. It's a common problem, actually. So you hold one hand, they try to evert, and you try to invert, but be gentle. You don't want to hurt them, and watch out that they're not firing this muscle. To manipulate the ankle, and we'll do this at workshops tomorrow extensively. Terry gave me the 2-minute sign, so I will go quickly for this. But basically what you do, and I have thanks, Jim, for teaching me this many years ago, that you can mobilize the fibula head in several ways. You just put your thenar eminence underneath the fibula, and you're going to force in like that, make sure their knees are not arthritic or in pain, and you can mobilize the head that way. And then the base is mobilized by tractioning the foot and holding it. Long traction with your fingers anchored over it, and this is the key part, is the longer you hold the traction and distract the talocrural joint, the easier the adjustment's going to be. And you don't have to be a bull in the china closet with these. This can be gently done. There's no reason to kill people. It's not necessary. And then really what it is you take them through full range dorsiflexion, and then you adjust in a downward way. The effects of this type of thing are this is a pre, this is a post, and the range of motions do change rather dramatically. To adjust the cuboid, cuboid's fairly central on the foot. It's really located more towards the middle than you would think. Marked it here. I use my thumb to do this, and I place it like a piston directly under the cuboid. If they've sprained their ankle or hurt their foot, this is a highly sensitive location, so you want to be careful when you press on it. And the key thing to do, you can press into it, but what you want to do, and I learned this from Paul Keneally in Australia, is you take the foot, you press your thumb under the cuboid, and you could see the tears roll down their eyes, so be gentle. Hold it there, and then with your other hand, very slowly and gently, because there's a very discrete release, very slowly and gently invert the foot until you feel the cuboid relax, and it does, and they'll tell you it doesn't hurt anymore. And then as you do that, then you can take it, then you take their toes, you plantarflex them, it'll release again, and then just give a very gentle shove under, and you're rotating it back, because it was everted from the injury, so you want to invert it, and you rotate it back, and that gives it its range of motion again. Lateral column range moves very nicely, and just more views of that. Quick thing, this is a 55-year-old diabetic male who sprained his ankle going down a set of stairs. He had x-rays, everything was good. He had to walk to maintain his weight because he was a serious diabetic, but he just had unremitting pain. This is weeks and weeks and weeks later. You can see how limited his dorsiflexion is, and I try to move the lateral column. There's usually a crease that forms right here that you can see when at the calcaneal cuboid joint. You can see that move. We'll do this tomorrow in the workshops. And this is the opposite side, which has normal dorsiflexion. And you can see that little crease develop right here because, see that right there? That's from moving lateral column. So. And then that site right there. And that's pre and post. So you could change range of motion immediately by practicing these techniques carefully. That's lateral column improvement. And so the key thing here is that pain is complex following ankle sprains. It's not direct cause and effect. It's a very complicated loop that creates. And tissue damage is only one of the reasons they have pain. Learning how to practice manipulation and restore range of motion and muscular recruitment changes everyone's lives, yours and theirs, because it's so rewarding to have these people come in and be unable to walk, and all of a sudden you help them and you change their life immediately. People pat you on the back, everybody walks around with big smiles, and you'll see it's a great way to practice. So thank you very much. Questions? Yep. Be happy to take questions if anybody has any. None. All right. Yes?
Initially then, are you still...
Wait. Yep.
So initially when they present with the ankle strain, are you still leaving that first to settle and rest till the swelling goes down, or do you do that immediately?
Oh, no. I think depending on the nature of the injury. First of all, you would certainly get an X-ray to see what, and a lot of this, there was a Quebec ankle sprain study that showed when to X-ray and when not to. If the pain, based on the fifth metatarsal, lateral malleolus, if those are painful to palpation, it's probably a wise idea to get an X-ray. If it's swollen and it's especially erythematous, it may be fractured, so you want to check for that. And certainly if that's the case, that's a different problem, and now it has to be immobilized. But if you find that there's no osseous damage, and you can compare range of motion, you can do these things very gently at the time of the injury or shortly thereafter, and have tremendous change. One of my son's friends came in just the other day, had sprained his ankle, and my son's older, he's 35 years old, and he was playing basketball and sprained it. It was like this. He x-rayed, he was fine, there was nothing there, and he came in, he could barely walk, and he walked out, and gee, doc, that's great, I'm so happy you did it for me. That stuff happens all the time, I do it all the time. But the rewarding ones are 6, 8, 10, 12 weeks later, where they still can't walk, and they come in with, a boot and an ace bandage and whatever else they have on, and they can't get around. And the immobilization could be just so fast, and because once peroneus longus facilitation has been created, all of a sudden that sense of impending doom of rolling the ankle is gone right away. It just goes away, and that's the sense. Any other questions? I think we can continue. Thank you all. Appreciate it.